So hi guys and welcome to this session. So part 2 session of this integrated system. So I am going to discuss some important topics such as pleural effusion and pneumothorax and all. So let's discuss today like what do you mean by this pleural effusion. So normally some fluid is present in the pleural space that is known as normal pleural fluid. Sorry, normal pleural fluid is 5 to 15. If the fluid exceeds greater than 15 or 20, so then I will get 20, 30, then whatever it may be, then I will call it as pleural effusion, right? So look at the chest X. Chest X-ray is very important. So it has been asked more n number of times. So look at the X-ray over here. And if you look at the X-ray over here, you can find like one side of an X-ray is completely fine and other side is like, look at this half part, like it is completely white. Why? Due to the presence of the fluid. The fluid is present over here. So that's why. So here some curve is present. Here one curve is present. This curve is known as Ellis curve. Okay. So the curvature that I have drawn in front of you in red is Ellis curve. And you can see over here there is a blunting of an costophrenic angle. So I will rub it. So this is best. A blunting of an costophrenic angle. Where you are going to find this blunting of an costophrenic angle? In pleural effusion. Blunting of costophrenic angle, right? And what are all the clinical features that you are going to see due to the presence of a more fluid? If I do like percussion, like stony dull percussion, you will find like if the water is present in the water bottle and if you hit it on like with your hand, you will get some dullness. No, that is called as stony dull percussion. So where you are going to find this stony dull percussion? In pleural effusion. Stony dull percussion. And tracheal shift, so we cannot diagnose on based on the tracheal shift. So that's why I'm not mentioning that. And what about the breath sounds? Diminish breath sounds. Remember, I'm not using the word absent breath sounds. So if I use the word absent breath sound, then the whole graph will become different, and that will be in the pneumothorax. This is diminish breath sounds. So this is also called diminish. Is also called inaudible. Okay. So there are two types of an pleural effusion. One is transudate variety and next one is your exudate variety. So what is the reason behind this transudative pleural effusion and exudative pleural effusion is if there is imbalance between hydrostatic pressure and oncotic pressure, that is transudative variety. What do you mean by this exudative variety? Is mainly due to inflammation. Okay. So this is about transudative variety. Imbalance hydrostatic pressure. So I told you no, there is an 15 ml. So this 15 ml, some amount of fluid that is coming out and again it is going in. So this is done by hydrostatic pressure and oncostatic pressure. So this is coming down, going up. So there is a balance is present. If that balance get disturbed, if the hydrostatic pressure will increase than oncotic pressure, so they will get transudative variety of pleural effusion. So and one more thing is some criteria is used to differentiate whether it is a transudative variety or the exudative variety, that is known as Light's criteria. Okay, Light's criteria is used to differentiate whether it is a transudative or exudate. So I will take this pleural fluid protein and sorry, serum protein, and next I will take this pleural fluid LDH and serum LDH. If my value is greater than 0.5 and my value is greater than 0.6, right? So then it is indicates exudate variety. Okay, understanding? This is exudate variety. If all the protein 0.5, LDH 0.6, that indicates exudate variety. If the above condition it do not satisfy, it indicates transudate variety. Okay, so this is about Light's criteria where you used pleural effusion. And how do you treat? Management by a process known as thoracosynthesis. So what I am going to do, I am going to put the needle on 8th intercostal space between posterior axillary line. PAL is nothing but posterior axillary line and mid scapular line. Okay, so this is the site for thoracosynthesis or pleural tapping. So how much amount of fluid you can remove per setting is 1500 ml. Only this much you can remove. So why I cannot remove more than this? Sorry. So I can remove only 1.5 liters. So 0.5 1500 ml, right? So if I remove more than this, that leads to shock. So there will be an imbalance, fluid imbalance, right? So that's why the patient will go to the shock. So I cannot remove more than this. And next is pneumothorax. So what actually happens in this pneumothorax is nothing but, so imagine you went to an ATM line, you are taking a money from outside and robber came and he want to take money from you and he took the knife and he just injured on your chest. So what happened? There is a creation of a hole in your chest. Whenever there is a creation of a hole in your chest, the atmospheric air, it will get entry into the lungs. No, it's like if you take the car tire, no, if you put the air and it will be going inside and it won't come back, same phenomenon, no, like it will be going inside, so that will leads to shift of a trachea to the opposite side, and it also leads to, it will compress all your superior vena cava will get compressed, SVC will get compressed. So that's why if you check BP of this patient, it will be very low. If the BP is very low, then that pneumothorax is called tension pneumothorax. Okay, so this is very important, like BP is low, tension pneumothorax. So like air is going, keep on going like an one way, it is creating one way valve over here. Air is going, but it is not coming out. So that's why you'll find absent lung sounds. And if you look at this, like, no, look at this is known as deep sulcus sign, which I have mentioned. So look at the X-ray over here. One side of the lung is extremely black, which I have mentioned over here in red part. That is extremely black. So why? More air, whenever air is present, more the X-ray will become black. So that's why it is more black. One side of the lung is too black, and other side, look at other side lung. This one, it is completely fine. No? So this is about how to differentiate pneumothorax. And what are all the clinical features? Same like dyspnea, difficulty in breathing, and respiratory rate will get increased. So the patient will be using these accessory muscles for respiration. On percussion, you will get hyper resonance. Why? More air is present. So that's why hyper resonance. Stony dull, pleural effusion, hyper resonance, pneumothorax. Right? So these are all key points, very important. Hyper resonance and absent breath sounds are seen in pneumothorax. And how do you treat? You are putting a large bore needle in the fifth intercostal space. So large bore needle in fifth intercostal space. Okay, fifth intercostal space, where the location anteriorly to mid axillary line. Okay, in child, where you are going to put this needle? In second intercostal space, mid clavicular line, okay, MCL is nothing but mid clavicle line, okay, and all these are temporary, but it is an first you want to do this, and after that you will put this chest tube or intercostal drainage. ICD is nothing but intercostal drainage. So if they ask where ICD is inserted, don't answer and come above. It is inserted in fifth intercostal space in triangle of safety. Okay, so what is the boundaries of triangle of safety? A, P, I. Anterior, posterior and inferior. Anteriorly we are having pectoralis major, pectoralis major, and inferiorly we will be having latissimus dorsi, posteriorly sorry, and inferiorly I am having fifth rib. Okay, anteriorly pectoralis major, posteriorly latissimus dorsi, inferiorly fifth rib. So this ICD is connected into UD, underwater sealage drainage system, right? Underwater sealage drainage system, UWS. So in this underwater drainage, so there will be bubbling, right? So remember these 3 points, it can solve a lot of MCQ. If the bubbling is intermittent bubbling, then that is normal. So ICD is connected to underwater chamber, underwater chamber. In that underwater chamber, if you find this intermittent bubbling, that is normal. If you find continuous bubbling, so that is indicates air leak. If there is no bubbling, bubbling stops, then you can think about your tube got kink or lungs got re-expanded. Okay, so this is the pneumothorax, and these are all very important IPQs in respiratory system. So these are all used in asthma. So with what is this which I have mentioned over here is meter dose inhaler. So that is also called MDI. Okay, so this is meter dose inhaler. So before using this, so some questions have been asked. Shake the inhaler well. Shake the inhaler for how many seconds? 5 to 10 seconds. Okay, and inhale for how many seconds? 3 to 5. Sorry, I will write it clearly. 5 seconds. Okay, and hold the breath for how many seconds? So hold the breath for 10 seconds. So not 30 seconds, no. So just imagine you just hold the breath for 30 seconds. It is very difficult for us only. So then how asthmatic patient can hold, right? So now previously they used to tell 30 seconds, but here it is only for 10 seconds. Okay, and exhale slowly. These are all the steps that you are going to perform by using this meter dose inhaler, no? So very important. And now what is this? This is meter dose inhaler, which I have explained it earlier, and this is spacer, right? So this is MDI plus spacer. Okay, so if the children is present, so then what you are going to use? This is MDI plus spacer plus mask, face mask. So this is used for the child less than 4 years, right? So then I am going to use, because they don't know how to use, no, like, so that's why. So what is this? This is soft mist inhaler. Soft mist inhaler. Okay. So this is easy to use. This is easy to use. So how much it can deliver? 40 to 50%, right? So it can deliver the drug. And what is this? This is dry powder inhaler. So Dry powder inhaler, how much it can deliver the drug? Only 20 to 40%. So best is DPI, dry powder inhaler. So it is very easy, no, like it does it. See, look at this, how the drug is coming like in foam, right? So it will be having the battery, and if it will be having the battery, if I fix the battery, it will work, right? It is very easy to carry also, and it can deliver more also, 40 to 50%. If you come to this MDI can deliver like it's very less, that is 10 to 20. Okay, so this is the how much drug they can deliver and all. MDI we know, meter dose inhaler, how much they can deliver. These are all very very important IBQs, so please go through this very carefully. And next I will discuss some spirometry values, and very easy and very simple also. So look at this, the amount of an air that moves into the lungs with each inspiration and with each expiration, like your amount of an air that you are doing normal breathing, so you are not putting any extra efforts and all, you are just doing inspiration expiration, inspiration expiration, inspiration expiration, and quiet breathing, no, this is known as tidal volume. Okay, so this is about tidal volume. So, so we are all having that extra capacity also, no, to accumulate some amount of an air. So like generally we used to study like 5 hours to 6 hours per day, but we have the capacity to increase to 8 hours to 9 hours per day also. No, we can put some extra efforts, right? So that is called, after putting some extra efforts, some amount of an air that I can accumulate in my lungs, that is known as inspiratory reserve volume. Okay, and some amount of an air I can expel out also after an expiration, right? Passive expiration, that is known as expiratory reserve volume. And after maximum effort, after putting my maximum efforts also, some amount of an air that will remain in the lung itself, that is known as residual volume, right? So this is about residual, and most of the students, they will be confusing between residual volume and functional residual capacity. So the amount of an air that remains in the lungs after maximum expiration is residual. After normal expiration is functional residual capacity. Okay, so these are all about lung volumes, and I will show you one more this also, right? Like I will show you the diagrams also, please don't worry. So if I add the lung volumes, I will get lung capacities. Capacity is nothing but sum of the two volumes. Okay, if I add all TV, IRV, EV plus RV, then I will get total lung capacity. So I will show you. So what is this? TV normally 0.5 liters, IRV 3 liters, ERV 1 liter, residual volume is also 1 liters. Okay, so if you put all these values over here, TV plus ERV plus RV, tell me, so how much it comes? IRV is 3, TV is 0.5, ERV is 1 plus RV 3, 4, 5, right? Sorry, like 3, 4, 5, and the total lung capacity is 5.5 liters. If I remove residual volume, so I taught you know residual volume is the volume which is not at all coming out from the lungs. So that's why that is the volume which cannot be measured by through the spirometry. Okay, so name the value that is cannot be measured by through the spirometry, that is residual volume is the volume which cannot be measured by through the spirometry. For living, we all need only which are very very essential, no? So like I will remove this residual volume, and TV, IRV plus ERV, what does it indicate? It indicates vital capacity. So what about this IRV? 3, TV 0.5, ERV 1. So how much it is? 4.5 liters. So if I combine TV plus IRV, so that is we know capacity. Which capacity? Inspiratory capacity. And TV plus IRV, I am combining these two, that is capacity. Which capacity? Expiratory capacity. If I add ERV plus RV, that is functional residual capacity, FRC, it indicates functional residual capacity. So it is also, if you know the above slide, you can solve this TV plus IRV. Just put basic mathematics, put the values, and you just add it. Okay, and label the part A. So look at this: inspiration, expiration, inspiration, expiration. This is tidal volume. So I can accumulate more air in my lungs. That is IRV. This is IRV. And I am expelling, that is expiratory reserve volume, some amount of an air that is not at all involved, that is residual volume. Okay, so this is about lung volume. So if I want to add this A plus B, what does it indicates? TV plus IRV, A plus B. So if I combine both this TV plus IRV, what does this indicates? Capacity. Which capacity? Inspiratory capacity. If I add B plus C, TV plus ERV, what does it indicate? Expiratory capacity. Okay, if I add all A plus B plus C plus D, what does it indicate? Total lung capacity. Okay, and what does this A plus B plus C it indicates? Tell me. Vital capacity, right? And RV plus ERV, FRC. RV plus ERV, that is C plus D. C plus D. What does it indicate? Functional residual capacity, right? So this is about spirometry values and very, very important. Respiratory is a scoring subject, and ABG, please watch my ABG classes carefully, and definitely you will get on very good marks. And this, so that's why I have simplified all the topics in this part 2 and my part 1 classes. So I have completed my respiratory system completely. So thank you for hearing, guys, and keep studying.